Okay, good afternoon. Thank you so much for joining us for our second Nursing Grand Rounds. My name is Rebecca Thacker. I'm the Director of the Center for Nursing Excellence Research and Magnet here at UAMS. And we are very happy to collaborate, the Center for Nursing Excellence, to collaborate with the Advanced Practice Provider Council to bring you Nursing Grand Rounds the first Wednesday of every single month. A special thanks to Brittany Buemeller and Tracy Motes, who brought this idea forward, and Destry Thomas in clinical education, who takes care of all the communication with the presenters on the background, make sure that we have all the forms that we need to provide you the CEs, the continuing education units, for everybody who's here in attendance. The purpose of Nursing Grand Rounds is to provide a forum for nurses to share their clinical expertise and experiences, evidence-based practices, research, and other topics of interest to advance nursing practice and patient outcomes. It does fall under our nursing excellence model here. So this is the UAMS nursing excellence model. We embody excellence through engaging, elevating, enhancing, and excelling. And today you are engaging not only in continuing your education, but being involved in hearing about the experiences and the practice of other care providers. Topics for Nursing Grand Rounds will include new initiatives, healthcare policies, clinical case studies, new innovation that we're bringing or that we hear about in nursing practice, hospital initiatives, and those sorts of things. If you are interested in being a presenter for Nursing Grand Rounds, we have more information on the UAMS website, nurses.uams.edu. And to receive credit for today's session, you do need to text the top number to 501-406-0076. If you are not aware that it is only open for a certain time frame, so even I emceed the event last month and didn't get the credit because I forgot to text in the number. So please take just a second right now to text in your number so that you can get credit for this session. I'm also going to show this number at the very end for those that might trickle in. It is now my pleasure to introduce you to today's speaker for this session, Donna Malone. She's a UAMS nurse care manager, and nursing was a second career for Donna. She worked in physician recruiting and business development prior to obtaining her BSN at UAMS in 2010. She began her nursing career at Regional One Health, which was previously known as the Med in Memphis, Tennessee. And for the first 5 years, she was primarily in the general ICU. But from that experience, she moved on to patient education, home health, hospice, oncology, and finally care management. In December of 2018, she moved to Benton and began working in the UAMS Care Management Department. Please welcome Donna.
I think I'll go right into my PowerPoint.
Yeah, you just have the next button.
Hello, everyone. So I'm going to talk today about transitions of care. These are our objectives, but basically we have to remember that healthcare is a business, and therefore the insurance companies that we deal with, the post-acute care facilities that we deal with, they are in it to make some money, maybe not get rich, but not to lose money. So with that in mind, that might help in our decision-making as we order our post-acute services. So we today are going to talk about LTAC, which is a long-term acute care hospital, inpatient rehab facilities, IRF or acute rehab, skilled nursing facilities, long-term care facilities, home health, hospice, and 24-hour caregiving services. So LTAC is the most expensive of our post-acute services. Their average length of stay is 25 to 30 days. Most insurances do require a 3-night stay in the ICU or step down. I say most, there are some commercial insurances that do not require that. So the patient, the triggers that I have on the board there, one in particular, if you know that this patient's going to take a long time to wean, a Medicare patient actually can get approved up to 45 days at an LTAC if they place the trach. Now, a lot of your managed care plans will not allow them to come without a trach. So it depends on the insurance. But that's something to keep in mind. LTACs can do wound debridement. They can do bronchoscopies, paracentesis, thoracentesis. They can place dialysis catheters. Of course, they can place those trachs. They can place the PEG tubes. So early on, if you recognize this as a patient that needs to be at an LTAC, the earlier the referral, the better of us being able to get that. Because remember, it's no one wants to lose money on what on the patient. So it's all about streamlining those services. Sure.
Yeah, we're having.
They can't see the slides.
Oh,
So I'm gonna
okay.
just stop. Sorry, technical difficulties, but we want to make sure everybody online can see.
Yeah, sure. There it goes.
There you go. I'm so sorry.
Okay. So back up a little bit. As we were saying, the LTACs are, these are the triggers. Wound debridement, I don't think that one was on there, but someone that has complicated wound care, they can do wound debridement. So that's also another trigger. And again, it's earlier the better. They can take patients in restraints at an LTAC too. Inpatient rehab facilities. These patients, their average length of stay are 10 to 14 days. It is, they need to be able to tolerate 3 hours of therapy a day or 15 hours a week. Medicaid will, the Medicaid patients can go to these facilities, but they do need to be freestanding and not attached to a hospital. Let's see, I'm sorry. These patients also can go in observation status. There's no a requirement for them to be in the hospital, so they can come, be here one night and go to an acute rehab if appropriate. They can take surgical drains if they have decreased output and they have specific instructions on when to remove. They can take IV antibiotics, just not continuous. Wound vacs, rule of thumb with the wound vacs is if it's locally and you change the wound vac out that day, then we can clamp it right before they leave and send the patient. Otherwise, wet to dry. In particular, if it's not one of the local facilities, could be that their wound vacs are not compatible with ours, so therefore the wet to dry is more appropriate. No cardiac monitoring is available. However, you can send them with a vent monitor. There is a diagnosis criteria with inpatient rehab facilities. They, so like strokes, spinal cord, congenital deformities, amputation, major trauma, burns, brain injury, some hip fractures with certain criteria, neurodisorders, and polyneuropathy. Are the and those are really strict with a lot of your managed care plans in particular. One thing that is new is Encompass can now take TPN patients and dialysis patients. This was not available to us before, so that's something new and recent. We also have started a pilot with the spinal surgeons. Oops. Where how it came about is that they are identifying patients in the clinic. So they're scheduling their surgery, and they know ahead of time this patient's going to need rehab. They, no doubt. So they are now sending right now. Again, this is a pilot. I'm the one taking the referral at this time, and then I am finding out the patient's choice and going ahead and sending the referral to the inpatient rehab. So what we're doing basically is making a reservation for that patient. So then that patient, they've got it on their board. They know that patient is going to come and when their surgery is, what kind of surgery they're having. So all of that's kind of being done ahead of time. And of course, therapy is also brought in on that. So they also know and have it on their calendar that this patient, what the expectation is. So far, now we've not done very many, we just got this started, but everyone that we've done so far, even with some managed care plans, have gone the day that we had it, that they were medically ready to go. So we are seeing some good results so far. Oh, it didn't change here, but changed there. Okay, there it is. Delay.
There's a lag.
I was just like, okay. Skilled nursing facilities. They do have a 3 midnight stay in just inpatient status. Now that means inpatient status, not OB status. There is an exception to that. That exception is an ACO patient, which you would see over in the banner. But they can't just go anywhere. They have to go to a Medicare approved facility. We do have a list in case management for those patients, and those patients can go in OBS. But those are the only exception on that. Their length of stay is longer. This SNFs are really designed for those patients that need longer to basically rehabilitate and probably can't tolerate the 3 hours of therapy a day, 15 hours a week, but they're still going to get therapy every day, at least 5 days a week. But at a kind of smaller increments. This length of stay, Medicare allows 20 days at 100%. After that, you're looking at copay days. Those copay days can run up to about $200 a day. So most people aren't going to be able to stay in those copay days. But if they have a supplement, it will pick up, and then they can stay up to 100 days. So that's all, a good option for some of our older patients in particular that need a little longer time. They get to get PT, they get OT, they get speech. I did put on there that the nursing staff is primarily LPNs because there are some, sometimes they'll tell you that they can have to receive the patient at certain time. And part of that is that they only have an RN there, certain hours of the day. And that's also why they restrict their IV therapy usually to their IV antibiotics to once a day or twice a day. Also need to be mindful that they are being paid to rehab the patient. So we do not want to schedule a lot of appointments and MRIs and things for them to do here and have them transporting back and forth. So that's important as well. I put on there about motor vehicle accidents. Those are always trying to get placed. Part of it is that their time frame for being paid can be quite lengthy if there's been a motor vehicle accident because there's a third party involved. There's the auto insurance. If it's a one-car accident, usually we can get around that and get them to a skilled nursing facility. If there's a lawsuit pending, you can forget it. We're not going to get that. That patient's not going to be going anywhere but here, unfortunately, and home. Let's see. Also wanted to mention on skilled nursing facilities, they can qualify without therapy. They can qualify for just needing a nurse. So that would be like daily wound care or IV therapy that can qualify them as well. And one other thing that is fairly new that we have, we are now doing the prior authorizations, we being care management, for the Humana and United Advantage, Medicare Advantage plans. We are getting a turnaround on those now at less than a day. So that's been also very helpful. Long-term care. So I bring this in because a lot of times we get a patient that, comes in, might be stroke, that's what comes to mind first, and some of these major traumas, that they lived alone prior to this. And it's pretty clear that they're probably not going to be able to live alone again. They're going to need someone there. That dialogue needs to start as soon as possible because long-term care is either private pay or you fill out a long-term Medicaid application, which also requires a lot of if they have a life insurance policy with any money, they've got to prove, show that. if they've got to do bank statements. And if your patient is not able to access those, that's a process. Remember, these are businesses and they want to get paid. So they're going to make sure that we've got a discharge plan. So that, discussion should start, that is the patient going to go home? Is there going to be people there? Or are we looking at a long-term care facility? We do usually transition those patients from SNF. So, we send them and then they can, because those are the same facilities. They have designated beds for long-term care and designated beds for rehab. So again, though, the key there is just start that dialogue early. Home health. Home health, we can order PT, OT, speech, an aide, a nurse. SN is what they use in the home health field, skilled nurse, social work. All of those are available through home health. However, they're not available throughout our state. They're also, Medicaid does not allow anything but a physical therapist and a nurse. That's the only two they're going to pay for. So ordering anything else is not what you won't. We're not going to be able to get it. And there's only so many visits per year. Also, a new thing with home health Medicaid is they have a copay, $4.70 per visit. This can be a hardship for these patients on these fixed incomes. And that's also, again, your home health being the business, they want to make sure they're going to get paid. So that's going to be an issue probably in the future as well. That just rolled out recently. That's a new thing. Also, OT, you think they just need OT. Well, you can't just order OT. They have to have OT with either physical therapy or a skilled nurse. Only a physical therapist and a nurse can stand alone with a home health order. So you have also to keep that in mind. Home health will not take motor vehicle accidents. Because of the same reason about not being able to get paid. So we tried, we beg, we plead, but it just doesn't happen. And the VA, if you see VA community care as their insurance, that's an authorization process. If you know early on that patient's going to need home health, let's start that referral early on and get that over so that their liaisons can get to work on getting that approved. Because everything takes time and we want to move that patient on. That's earlier the better. In the outpatient setting, a face-to-face, that's what they call it, but basically that's your office visit. So that along with the order needs to be the same provider. So if you place the order in the clinic, you need to follow that patient and those orders from then on. They need that to be the same. In the hospital, the key there is to make sure that who's going to sign those orders. Well, that can be a problem if they don't have a primary care provider. So, like our hospitalists do not plan to follow that patient. However, they hadn't seen their PCP in 5 years. Well, home health is not going to come out until they have a provider that's going to cover, because again, they're not going to get paid. And really shouldn't be out there without a physician following them anyway. So then we've got to make sure we have the primary care set up so that patient can see that physician quickly so that home health can get in there and help with the patient. Hospice. Okay. So hospice, obviously they can go home with family. Something to remember though with hospice is not a caregiving service. So you still need family members, or they can pay caregivers to come in and help with the patient. If that is not available, then we're looking at long-term care. Insurance does pay for the hospice benefit, but long-term care is considered a resident, so you've got to pay for it. So, and as we've mentioned, that could be up to $200 a day, or the Medicaid process, which most people in hospice, that's kind of a lot for them to do if that's. So, but keep that in mind. That is a separate payment there. General inpatient, GIP is considered, it's short term. It's for basically they cannot manage those symptoms at home. Typically, commonly is like the IV pain meds. If that's what they need to be able to control their pain, then that's appropriate. Sometimes increased secretions where they're needing frequent suctioning because that is a comfort measure. Then those could qualify. In particular with UAMS, because I know there's been some confusion on that. UAMS with Arkansas Hospice was set up so that those patients that are too unstable to transfer can stay here. But we cannot tell the patient they can stay here. Only Arkansas Hospice can. They make that decision as to whether or not it's, they're too unstable or if they can transfer them to their facility. 24-hour caregivers at home. Again, we're looking at private pay. We're looking at a Medicaid waiver program. Again, that's an application process. There is another waiver program too for those over 65, but I was told by one of the caregiving services, the most they usually see are 14, 15 hours a week. So obviously that is not 24-hour care. So being paid for. So that is also something to be mindful of when discussing that, because we're not looking at 24-hour care with caregivers. And I wanted to put in one last slide about hospital at home. This program started at the end of June. And it is a CMS waiver program that was set up and is supposed to go to, right now it's set up to go to the end of 2024. And one thing to remember is they have to meet inpatient criteria. It is not a discharge, it is a transfer. And what is confusing about that is they are picked up by an ambulance. But if you think about it, if you transport somebody from one unit to another, you also don't let them just walk down there, you transport them. So the transport has to be a ambulance, but they are still considered part of the hospital, inpatient status. They have nurses that come twice a day. They can come up to 3 times a day. They do get a telemedicine through hospitalists. They're rounding once a day. They can also do specialists that can telemed in. They get PT, they get OT, they get speech if ordered, and they can do x-rays, echo, ultrasound. They do daily labs, but their daily labs are done at 8:30. So, of course, this is a perk because they're not being woke up at 4 in. One of the perks of it is that they do get better sleep. They can't do IV therapy or IV pain meds. They can, any drips that require like 2 nurses to sign off on. So like your heparin, your blood products, cardiac drips, they can't do those. But but they can, like I said, the nursing twice a day, so they can do the IV antibiotics. Just needs to be during at least twice a day. One of the perks of this program is it was quoted in AARP that it's an 38% decrease in cost for the Medicare to have these patients at home. So it'll be interesting to see what they do at the end of 2024. But like I said, the sleeping better, the decreased confusion with your elderly, obviously decreased exposure to infection and germs is a perk. Most of them find that they move around more because it's less restrictive at home. So those are kind of some of the perks of that program. Does anybody have any questions?
Can you hear me?
Yes.
Okay. With the hospital at home program, do you know why we have to block inpatient beds for that per patient?
So should they, something happen in the home that they need emergent basically care, they basically transition to maybe needing ICU care or something higher than what they can provide at home. That's why.
Okay, versus like just taking them back to the ED, which is.
Correct.
It's a better process.
Because they're still in the hospital. But, so they have to be considered, basically it has to be a direct transfer because there still are extension of us wherever in the home.
Just do like that.
I have a question while our table is free. Thank you, by the way, this is wonderful. Are we recording this? Yes. Okay, this needs to be sent to all of our provider partners.
This is a wonderful summary of how all this works. And then also at hospital at home, do they have to have a caregiver present at all times or can they be? Okay.
So is it a provider decision? Which of them is qualified? Like, in my mind, does hospice qualify for hospital at home, or do some of those LTAC patients qualify for hospital at home, or is it completely separate?
Well, so like, well, if they qualify for hospice, then you really should discharge in hospice, take it. So it's got to meet inpatient criteria. And I did forget to mention this, it has to be within 30, they have to live within 30 minutes or 30 miles is what is kind of their criteria.
For the hospital at home?
From UAMS. So obviously somebody that lives too far out would not. But they, again, and that's kind of like, that's what's so hard. And it's been hard for me working with the program of wrapping my head around, well, that sounds like home health, but they've got to meet inpatient criteria. That's the main thing. If they don't meet inpatient criteria, they have to be discharged to one of the post-acute facilities.
So if they were appropriate for like an acute care rehab, an inpatient rehab, they wouldn't probably be appropriate for hospital at home. Is that what you're saying?
Right. Now there is a program with hospital at home that is rehab. We don't have that yet.
Okay.
But that
I'm
is
just trying to think of what's appropriate for.
right.
Yeah, the volume capacity, like how many patients can they take at this point from UAMS?
I think their overall is I've heard a range because of course, as you all know, staffing is always an issue. But 6 to 8 a week is supposed to be their goal. Or a day, 6 to 8 a day, I guess.
And how long can they be in like, how many days do they have of hospital at home?
Well, it depends. Again, as long as they're meeting inpatient criteria, they can stay. But once they don't meet, just like here, once they don't meet that inpatient criteria, we discharge them, whether that be to, stay at home and we'll order home health, or we have had some that go to a skilled nursing facility from home too.
Are we staffing more than 6 to 8 beds a week in the hospital?
No, those that Contessa employees are the hospital at home. They are,
But if we have to have the inpatient bed available,
Just have one block every day.
just one bed. Okay.
Because they're assuming like all of them wouldn't need to come back to the hospital.
I was like,
It's like having the code bed.
You were over here like, wait, how many beds are you walking?
It's like having the code bed.
and I do have a number of kind of some cards up here if anybody wants any of those to take. That if you had somebody that you think might be a good candidate, that's the number to call. They have what they call RCC nurses, recovery nurses that and do the evaluation.
I don't know if I turn that on or not.
Game show thing.
Alright, so Ms. Donna, you talked some about our motor vehicle accidents not being able to discharge because of that. If they have primary insurance, that is the payer source, and they're not seeking for the auto company to pay, does that still prevent us from discharging them?
Yeah, it does.
Should ask the trauma nurses.
Yeah, it will. Now, like, again, like a skilled nursing facility, if it's a one-car accident, they will, a lot of times we can get them to take the patient. I know when I was doing BPCI, I was able to get them to take, because we were, using our BPCI as a, part of it, that this was a bundled payment. So they did take those patients. But, if there's a lawsuit on it, I mean, you think about it, it could be years before anybody gets paid.
And then you said something about LTAC areas taking restraints. Will they also take sitter orders, and will any other facilities besides LTACs take restraints or sitters?
No, if they do, they're considered.
They don't do sitters, and I know that in my experience, they have restrictions on the restraints as far as they can be 2-point, but not 4-point. Like, so 2 restraints are okay, but if they're in all 4s, they're probably not quite stable enough
Is
to
it
move.
just LTACs?
Yes, and any other facility that I know of won't do a sitter or restraints or anything like that. So,
You have to think about it, LTAC is like an ICU setting.
Yeah.
If it's appropriate for an ICU, most of the time it's.
and I mean,
appropriate for
in
an
the
LTAC.
ICU, they don't really have sitters because the ratio is, so if you think about it like that, then it makes more sense, like she said.
Well, I'm just thinking about all these patients that are really at risk for falls when we take restraints and the sitters away just to get discharged. And at least we know an LTAC may be an option, and I was trying to figure out where other facilities an option too.
No.
We do have a couple questions online. Oh, I'm sorry. Do you want to go first?
I've already had several questions.
No, that's okay. So I heard you say on LTAC that they had to have, I knew about the 3 ICU midnights, but I didn't know about like the step down. So, we do decentralized step down at UAMS. So if somebody was in progressive care status on the floor, would that count? Okay.
Also, remember, these are insured patients if we're talking about LTAC. Like, a lot of these aren't. If you don't have any funding, a lot of them can't go to these facilities.
Medicaid.
Okay, we do have some questions online. It says, is there a particular time frame before a patient transitions from a SNF or LTAC to LTC?
Well, a lot of it has to do with running out of their days. So when they run out of their days, which again, remember, Medicare pays 20 days. Oh, sorry. Medicare pays for 20 days. So at 20 days, a transition of some sort has to happen. Whether it be you're going to pay the copay days or transition to long-term care. Now, in long-term care, they can get, I'm trying to think their wording for it. They can still get a little bit of rehab, but it's not called rehab. It's now, if I didn't try to do it right this minute, I would be able to tell you. But basically, it's like kind of keeping them kind of a maintenance type program, so to speak, where they are getting a little bit of movement every day, but it's certainly not rehab by any means. But it's
Skilled bed, I think is what they call it at the rehab.
right.
So this has been a very lively discussion. I think if you had a megaphone that you could say and speak a word to any direct care nurse, what would that might be?
Oh,
Like if you, yes, if you had, like, if one, if there's something that you always come up against, or that you're like, oh gosh, I just wish they knew that. What is one, or maybe, I don't know, 3 things? Because you have the ear of direct care providers. So
we are not a fan of the Advantage plans. Medicare definitely is easier to deal with for sure. But I think the message that definitely is the earlier, the better we identify these needs and start those referrals, the better off we'll be for sure. And especially if we are looking at a long-term, things are not going to be the same as they were before, like the patient that can't go back home alone. We need to start that discussion early on, because it's hard to wrap your head around. They were just fine, living by themselves, doing everything just yesterday. And now, we've got this life-changing event. And those life-changing events sometimes are very hard to get from where we need to go next. So, and same thing even with like hospice, if it's hospice appropriate, I mean, or we're looking at a very poor prognosis, I mean, introducing that discussion, because I mean, people don't usually just come right straight to going to hospice. They need to wrap their head around what is actually happening here. So
Do we still have an inpatient hospice option here?
it is limited by basically it was set up to be, like I said, if they were too unstable to be transferred. So it's really not set up to be a widespread inpatient unit here to where they can stay. Yeah.
I have another question. Donna, if you were like as a nurse that's maybe not as familiar with the case management part of, nursing and healthcare, what would be your best advice for bedside nurses or even providers, like familiarizing themselves with what their specific patient's plan of care might be? Like, is there a place that you would recommend them going in the chart or a person to talk to? So, because I guess my point is to say that it's good for everybody to be on the same page with these patients as far as discharge planning. And so where would be a good place for people to get on the same page so that we're not telling people two different things?
Right. Well, now, of course, care management should have a note in there, but we all know that notes have their own limitations. But the communication that we've been doing with Epic Chat, I think, has been very, very helpful. I know even when I have been inserted into certain situations, I try to include the nurse that's assigned along with the provider that's on there. And then, of course, the care manager that's already assigned to that patient. And then if I'm doing something, I will communicate with all of them. So I think the main thing is that open communication with everybody. Therapy should be involved if it involves anything to do with going somewhere. I think sometimes we forget about them because they're not right there all the time, but they are. But they're key to us being able to get them to like an acute rehab or a skilled nursing facility. So we definitely want to make sure they are involved also. So I think the Epic Chat is a really good place. And if people don't respond in that Epic Chat, but the reason I like Epic Chat is if you are gone for a little bit from your computer and you come back, there's that icon tells you you've got a message on there. So that's why I think it's a really good, because we all are up and down from our desk, obviously, but we're in Epic. So we are.
I think it's helpful too, if care management has the information of what the provider wants, like all the things they think they need at home, to know where they qualify. Because I think what I see is the providers don't always, it doesn't matter to them what their insurance qualifies them for or not. They know what they need. And so I think if they say discharge to BRI, if BRI doesn't have a bed, then the case managers are kind of scrambling to figure out more. So I think the more information that you can get from them, like the things that are needed, are more, rather than them try to learn all the ins and outs of what can go where and all that. If you have the information of what's needed, I think that is helpful too.
Well, that pilot we're doing with the spinal surgeons, I think has, and I think as we go even further along, but we actually had one that was in the ICU. Again, it was kind of designed for those to be identified in their practice, but this works too. So he called me about one that was in the ICU. And I said, well, when are they going to be ready? Because obviously they're in the ICU. They're not ready to go to acute rehab. And he gave me a time frame of when. And so I, again, made that reservation, so to speak. But in that particular instance, the patient's family had a different idea in mind. They really wanted them to go to a skilled nursing facility because of where they lived. And they knew the place and everything. And honestly, a skilled nursing facility is going to be easier for us to get approved with the managed care plan because it's cheaper. Remember, it's a business. So in that particular instance, I got a Humana patient we did the PA on Friday for a Monday discharge, got it approved within 2 hours. And then the patient went on Monday. I did the PA that day, so no, I'm not.
Oh, on H7, we sometimes get, stuck in insurance approvals. What's the deal on land,
On what?
on property? So like the patient, no, sir, it
The
holds
patient
them.
has like assets and they're trying to go to long-term care.
Yeah, they like won't pay for it, and it's like, well, they've got land in their name, so we got to verify that that hadn't sold and that there's not taxes owed on it. and all this. Well, hold on to these patients for weeks
Yeah.
and like waiting on all that to
So
feather out.
that discussion that I was talking about before, that patient comes in and you're talking about a life-changing event that is going to probably put them either somebody's got to be with them all the time, or they're going to go to a long-term care facility. If we start that discussion at the very beginning, because that, again, people can't wrap their hand around, they were fine and now they're not. So, that they've got to start getting in wheels in motion, because it's not a quick process to go to long-term care, because they do have to, and if they have any assets, they're going to take pretty much everything, because you're looking at long-term it's like paying for a house, if you think of it that way, because they're basically they're giving up their house to living with basically having 24-hour caregivers and a new residence, so to speak. So it is not, if they own the more they have, the longer that can take, for sure. And then nobody's going to want to give up that stuff, and then that's when the family's got to decide, well, do we want to rally around and take care of our loved one? Or do we want to give it all up?
Donna, we have another question online. Do you happen to know how many hospital at home patients you've transferred home directly from the ED and from inpatient units? Maybe ballpark?
We've had a total of about 50 patients, I think. So.
About 50 patients. Okay.
I do have a quick question. You talk about sooner the better. Sometimes for providers, nurses in general, we don't know what the outcome's going to be in advance. So we say, let you know soon. Is it okay to start the process for something that may not happen? Because it feels like sometimes that's a lot of extra work that may not actually end up needed.
Well, what I mean is getting them to be thinking that they may not be able to go home alone. There's a good chance this is life altering, and you have to word that delicately, obviously, because you don't know, but you want them to be thinking about that they may not be able to go home alone again. There's a good possibility that's not going to happen. And so if they start thinking about that, then they've got to be thinking about, oh, well, I work 20, all these hours, but so-and-so in the family, you just kind of get that started, get them to be thinking about how to prepare. That's really not necessarily doing anything just yet, but you want them to be thinking, because they're not going to think about that. They're not going to be thinking that far in advance, because like I said, they were fine just yesterday. So, the seriousness of the event, we know enough to know that more than likely that patient being home alone is a big transition after a major event. So planting that seed early on, that's probably going to be very likelihood of that happening is not good. That way they kind of start that thinking about, oh, well, okay, then they, you know what I mean? So that's kind of what I'm talking about with that.
I want to make sure we answer any last questions before we close that. Any last questions? Thank you to everybody who is participating on Zoom. Donna, it says you did an amazing job, and I would agree. Thank you so much for presenting today. I'm going to go ahead and advance to the activity slide. So if you trickled in late, in order to get your continuing education credits, you must text this number to 501-406-0076. It's only open for a specified amount of time. I told the group earlier that I emceed the event last month and didn't get credit because I forgot to text it in, and it was too late after that. We do hope that you will join us next month. We'll be having Ebony Green here from Neurosciences. She's one of our own APRN coordinators to talk to us a little bit about her role and what the patients that she cares for. And we want to offer you the opportunity to provide feedback on our sessions and also to give us information about, we'd really love to know more about this topic and that we can reach out to some speakers. Oh, that's not advancing. Oh, it's the last one. Oh, that's because I need to do this. No, I don't know. I need that to show. I need the QR code to show.
It showed up on hers,
But not in here in the room.
Oh.
We've had quite a few technical difficulties. I'm going to blame it on how cold it is in here because I know that I have difficulties when it's so cold. Yeah, it's not advancing. I don't know. Well, I do want to give everybody in the room the option to do that. So I may stop sharing on Zoom just so that we can see that here in the room. But thank you so much, everybody, for coming. Please bring a friend next time when you come. Bring somebody that you work with, and especially some frontline staff. We want to be able to try to get them in the room. We do offer it virtually because we want to be able to have everybody participate in a way that makes sense for them. But we would love to see more people here in the room. Perfect. There's the survey. If you don't mind to fill out the QR survey, we would really appreciate it. And thank you so much. Everybody have a great rest of your day. On the schedule just for that.
Give me a raise, I'll do it.
Oh my goodness gracious, I am cold. Oh. Yeah, I don't, so I guess when we made the pillows.